Hello, everyone. Welcome to today's webinar. We'd like to welcome today our webinar presenter, WSIB, who's going to be speaking about WSIB, Kinesiologists, and the new MSK program of care. My name is Savita Baja, and I am a kinesiologist as well, and the vice president with the OKA this year. I'd like to introduce our speaker, John Gray. He is the clinical lead at the University of Toronto's Master of Professional Kinesiology program, as well as the co-author of a book with Professor Stu McGill. He is a registered kinesiologist who has been working for over 25 years with clients who are recovering from injuries or managing chronic musculoskeletal and metabolic conditions, as well as facilitating return to health, work, and sports. He is a popular presenter with the OKA and has contributed towards education events such as discussion of the assessment, treatment, and management of MSK pain. He continues to contribute to the kinesiology profession through Movement First, where John provides educational courses to help kinesiologists excel in today's healthcare system. Today, throughout the presentation, if you do have any questions, I ask that you write them in the Q&A box at the bottom of your screen, and we will get to them at the end. Feel free to write them in as the presentation is going, and we'll have some time at the end of the presentation to go through them. At this time, welcome, John, and I'll hand it over to you.
Thank you very much, Savita. Hello, everybody. Thanks for joining me tonight on this topic. Before I begin, I also want to thank the Keen Committee and the OKA Board of Directors for the great work they've been doing this year, getting more outreach to the membership. I think that, being able to see a lot more happening. I mean, there's always been a lot happening, but oftentimes what happens is behind the scenes. And so everything from the updates and also the effort to putting these educational events on for the members, I think it's really positive, and I think it's showing an enthusiasm that I think is really good, and it's good for the profession as well. Tonight, I want to bring you the part two, let's say, of a presentation that was done by the WSIB for us back in March of the year, about 4 or 5 months ago, and we want to talk more about like the how-to, a little bit more of like the kinesiologist perspective on the new musculoskeletal program of care through the WSIB. So there we go. I really appreciate the intro. Maybe I could give you a little bit more of my background as well. Prior to, let's say, pre-pandemic, let's say, I was always really involved with the association with volunteering. I was the president of the OKA in 2001. I started volunteering and noticed that it did a great job for my career development as well, just by getting involved and learning a lot more. And that started in '97. After that experience, I did have a chance to sit on the inaugural council of the College of Kinesiologists of Ontario, and I was a peer assessor for about 7 or 8 years up until this year. So a lot of the reason why I'm now doing a lot more education is I now no longer have to worry about being in a conflict of interest between working for the college and then also doing promotional or advocacy work for the profession. So now I'm free and clear to get as public as I can be. Professionally, my business, I'm a solopreneur, so to speak. I see private clients in their homes and throughout Toronto as John Gray Arkin. And separately, I also see people at the Orthopedic Therapy Clinic in downtown Toronto. I've had a really long-standing relationship with them. That tends to be the source of most of my very complicated clients. And so we're talking like pre-post surgery, scoliosis, complex conditions, people with metabolic plus orthopedic conditions, etc., inflammatory arthritis, and those kinds of things. And so a lot of that's really informed what I do through Movement First, which is being able to work with those people and working in a multidisciplinary clinic. You learn certain skills through the years, and I really want to be able to provide that to my colleagues and to other kinesiologists so that we can all continue to improve. And definitely, the growth of the association and the profession so far, I mean, it's been recognized by the WSIB, which is why this new program of care is even available to us. So I'll talk at the last slide, I'll talk a little bit more about movement first. Lastly, you might have seen an email that came out of the OKA called the Kinesiologists Vodcast, and that's a kind of a fun project that I'm doing on the side with some people that I've met through, my work as a peer assessor over the years. And one of the things that was great about being a peer assessor was meeting these kins in these amazing jobs and roles. And I swear nobody ever heard of the opportunity to work in these areas. So this is going to be my opportunity to speak to people who are doing those jobs and really focus in on what they're doing, professionally, how they got there, what their needs are, et cetera. So I think it's going to be really interesting and exciting for particularly new grads, new kins, to listen to. At least I hope so. Okay, so for today's talk, I want to keep this pretty close to, close to our game, in a matter of words. I just want to talk about, what's the WSIB if you haven't, if you're not super familiar with it. It's only a couple slides. Really quickly, we're going to go through that. But why are our kins important? Like, why did we get this opportunity to go and start to offer services through the WSIB? I want to talk about specifically how I, as a kin, and I've helped some other kinesiologists kind of navigate some charts through the new program of care. And I want to talk about how you can either take these clients on individually, like you really can take a client or patient through the entire WSIB process, with the exception of the diagnosis, and we'll talk about that, straight from intake to discharge, and bill it completely for yourself. But most of you will probably be in a multidisciplinary setting where you're going to be working with other clients, other professionals. And then we'll talk about how that might kind of change things around and show about some opportunities for possibly career development. In that case, you could use the WSIB as like your mechanism to increase your skills, your responsibilities within your current clinic. Afterwards, when this video is posted in the Keen site, I'm going to make sure that there's a resource guide available to all of you for download that's going to go through a lot of what we're talking about here with a bit more direction in the way of like hot links to specific pages through WSB and other areas of interest. So firstly, what is the WSIB? Well, importantly, it's an insurance company, government-run insurance company that funds healthcare services for all Ontario employees who are injured at their work or occupation. And so all businesses are required to pay into this fund, though that money is used to pay for all of the services associated. And you could imagine, just like any insurance, the more claims that you have, the higher your premium is. So workers have a real, they're really motivated to try to keep their workers as healthy as possible, to keep their premiums down. They have a workplace that sees too many worker injuries, there can be penalties and steeper premiums as a result of that. So workers and the WSIB, everybody's really interested in getting these workers back as safely and efficiently as possible. Now, this doesn't just cover rehab services, could also cover like lost wages and other factors associated with getting workers back. In the previous presentation, the WSIB reps talked about here, this graphic on the right, really kind of talking about three different areas where the WSIB kind of can really influence worker health. So you have the OHAP, Occupational Health Assessment Program, specialty programs, and which are more kind of, it could be like neuro, ortho, those kinds of things. You could just think about like medical specialties whenever they're needed. Mental health is another good example where workers might need specific rehabilitation and medical services. And KINs are mainly used in what's referred to as community programs, which we're talking here, you know, programs of care, specifically the musculoskeletal programs of care. And there are a couple of other programs of care that are out there. Specifically, though, our big foot in the door with WSIB is going to be the MSK program of care that we're talking about today. But the thing is that we were chatting about this before the webinar started. It is very likely, as we continue to improve in our just in our size, in our effectiveness with programs like the WSIB program of care, Kinesiologists are going to be well, better known. They're going to be seen for producing, just really good results, being very effective health professionals. And what we should end up seeing is that kins are going to be involved in these other areas. I already know of one kin who's part of an OHAP program, and she works with a orthopedic surgeon in this case, and does assessments and reports under that. So I do think that we're going to see more and more of this. I did get a piece of information earlier from Steve Fisher. We were chatting, and in conversation, WSIB had said that the number of kins that are actually billing for WSIB at present is close to like 6% of our membership. So on the one hand, it's a tremendous opportunity for us. But on the other hand, we're still kind of very new to the process. And I think that it's a great opportunity when we're going through this. We have to also realize that there's a bit of an educational requirement that we're going to have to kind of assume when we're talking to people. Like if you ever need to call into the WSIB for any assistance, we'll get into that a bit more in later slides. So here is the thumbnail of the presentation that was done in March of this year. And just the new program of care is basically a culmination, just a synthesis of the previous ones that tried to make it a bit more efficient. And we also have Greg Gillum to thank. They mentioned him in the previous webinar as well. But Greg and I were on the board together. He has been a long-standing volunteer of the association and the profession, and he was there. A lot of what we're able to achieve today can be thanks to him. So why are our kins? There's a lot of different reasons why our kins are really important for the program of care. And I would say, like, I'm talking about very selfish reasons, okay? So definitely, this is a great way for you to build your clinical assessment intervention skills. And it is a primary practice source of referrals. So the fact that, so what's primary practice? We're talking about people who come in, they see you specifically, and then you can direct their care any way you like. WSIB is very clear that we are allowed to go through the entire program of care, again, with the exception of getting that first diagnosis, and we're going to talk about that a little bit as well in future slides. But if you have an interest in becoming a self-sustaining, autonomous clinical kinesiologist, either working completely as a solopreneur or working in you're renting a space in a clinic or working as a member of a multidisciplinary team, this is a really good model to learn. And we'll go through that a little bit more. Diversifying your funding sources. I mean, if you're reliant on a lot of out-of-pocket money for your clientele, this is a good way to kind of stabilize that as well. This is one of the few fully insured programs for kinesiology. The other one being the family health teams. And just to plug the vodcast again, if you haven't seen that, I mean, Zana Ouellette, who is one of the co-chairs of the primary practice community of practice, has a really great statement in there. It's all kind of divided up into chapters, so you'll be able to find that. And she explains this very, very well. But basically, that the whole video was talking to 3 amazing kins who are being paid by OHIP, and they are incredibly effective in influencing positively the health of their patients. So, outside of that environment and WSIB, hopefully we're going to see more on the way, because clearly we're getting noticed as a profession. Definitely. And if you've seen anything else that I've talked about, this last point here, raising your value in a multidisciplinary setting, the reality is the people who kind of get the best contract agreements, the best terms, etc., are the ones who really bring in the revenue into the clinic and help the business owner to pay the bills and to, improve their standard as well. So if you're able to find a way to bring business into the clinic rather than, it's one thing to be able to work with all the clients that you're assigned and do a good job with them, but if they don't generate more revenue on the business side, you might see yourself being overlooked a little bit. At least this will help against that. So the big thing with the program of care is the use of evidence-based interventions. Also another important thing. KINs have always been about evidence-based assessment and interventions. Everything, like back in the 90s when we used to put on, OKA workshops periodically, a really, really popular one was on measurement. It kind of sounds a little dry, but we were really known in the 90s for being the profession that emphasized measurement and accuracy of information that we're collecting. We're being very quantitative in all of our interventions as well. We're also being paid equivalent to any other health profession for doing services for insurers, like MVA insurers. Legislation changed and things kind of did a 180 on us. So, but this gets us back to our roots. So the WSIB program is quite important for that. But again, these are all areas where clinical kinesiologists should really pay attention to if you want to be able to provide complete care to your patients. Now, it doesn't mean that you have to do all of them, okay? But it is important that you, definitely within our scope, we have all of these 6 factors. You may use some more than others for different patients. And you might actually refer off for some of it as well, and we'll talk about that a bit later. Okay, so kind of going into that, if you think about the intake assessment and using that as a model for the skills that you need to develop as a clinical kin, we're talking about everything from subjective interview, objective assessment, your signs and symptoms, looking at posture, movement, range of motion, learning orthopedic and neuro and other special testing, which you might have. I'm sure some people watching this presentation right now are going to be saying that they've worked with people or are currently working with people who are very staunchly against KINs doing any kind of neuro testing or anything that might be a little bit on the perceived kind of dangerous side. The fact is, it's all in our scope. We're talking. There's an ongoing debate, and people tend to miss the difference between scope and competence. So if you don't have the competencies to do these kinds of things, you might decide to refer them to a colleague, or definitely not in the assessment. Hopefully at that point you will, but you should be picking up these skills as you're going along. So as a model for you for learning how to be a fully independent clinical kin, this is a good roadmap. Coming down to analysis, not only our clinical impression, but also understanding factors that are going to influence this person's progress, and coming down to a plan as well, SMART goals, etc. So within the assessment report itself, here are some of the things that they ask you to fill out. So under subjective, they want to know the history of injury, treatment history, past medical history. Objective assessment, neuro and special tests are definitely within our ability. You think about in your education, learning, understanding things like injury mechanism, tissue pathology, etc. This is really where your knowledge is going to be very, very important and useful. use of outcome measures. Now, the initial assessment report requires, or I should say, the program of care requires that you're using one or more of the outcome measures that they've determined. So that's like the oswestry for low back pain, the NDI, which is the neck disability index for the neck, the DASH, which is the disabilities of the arm, shoulder, and hand, and a couple of other ones. You're only allowed to use them. But when you take that questionnaire in at the beginning of the program of care, you would expect to be able to do it again on discharge. Hopefully you'll see a difference, but at least it allows more quantification of the program itself. Under analysis, we want a clinical impression, which is more than just like our version of a diagnosis. It's not just a play on words. There's more into the clinical impression than the diagnosis. We can talk about that a little bit later. But they do have this really weird term that they call occupational diagnosis, which every conversation I've had with a WSIB representative has given me a different answer. Unfortunately, we're going to run into that a little bit more when we talk about some of the other areas of the plan as well. But maybe we can leave that for the questions. But you also want to be able to identify things like contributing factors and barriers to recovery. And lastly, the plan and prognosis. You have to come up with a treatment plan. It's really good skill building to look at an injury, the extent where this person is in their recovery of that injury, even at the very beginning, and be able to say, or to be able to gain the skill and the ability to estimate how long it's going to take for that person to get better. So that's where the expected timeline and goals for return to work come in. So working within the MSK program of care. Number one is they have to know who you are. So you do have to register both with WSIB on their website, but also TELUS Health is the group that is going to handle all of the financial kind of like payment and receipt of invoices. When you go through, I didn't want to step through and do a long, boring thing. They are all pretty self-explanatory. We will have this in the resource guide as well, the links to go to. And you basically just step it through, you put your information in. TELUS Health will provide you with a registration number, which weirdly, sometimes you need when you're calling in to the WSIB for a question about a claim. Let's say you want to know, you have like some kind of a medical question, whatever it is. Sometimes they'll ask you for your registration number, which could throw you because you will have like registered through TELUS Health. And so sometimes it could, at least I found it a bit odd. That's the only number you're going to be given. When you register with WSIB, there is no number. You do get to be listed on their preferred providers directory. So there is a subpage of their website where you can verify that you've been listed, that you're able to provide services and submit reports through them. So the reports go through WSIB's website. The invoices go through TELUS Health. So here's the structure, and you've seen this before. It was in the WSIB webinar earlier this year. And what we have here is, there are some admission criteria. We won't go through it in too much detail. That presentation did a great job of going to all that detail, all those kind of details. Block one, let's say after you do your initial assessment and you identify the person is actually eligible for the program. Block one is 4 weeks. You have to see the person a minimum of 5 times. And then that is, you're basically allowed to start that off right away without any kind of specific approval. They want people to be able to get going as quickly as possible. Block 2 will require approval if the person, so if you're going to do weeks 5 through 8, generally speaking, it's not a big deal. But they want to create this nice clean flow through here to get people better faster. So you may have a case where you're going to need to call people, and this little chart here will go into, you see at least you've got 4 different groups to call. This is part of the strength of the program, there's also a weakness as well, because oftentimes what you'll have is you'll call in the clinical expert line and you'll ask them a question, and then you'll ask something about billing or some question related to the administration of the program. Then they'll refer you over here to customer service instead, or you might be speaking with a case manager who will then tell you you need to talk to the clinical expert, those kinds of things. The good news is that they always have a way to kind of direct you. So don't really worry about that. I just want to kind of give you maybe not the answers in this short presentation, but at least maybe lead you, make you aware of some of the areas that could be a bit of a bottleneck. So the previous one was what they planned it to be like. Here, like this left side of the drawing of the horse. In the reality, we end up having, as with all new programs, and I don't want this presentation to sound like I'm negative on the program. I mean, it's great to be involved with it. It's still rolling out. We have to be kind of realistic that in the first year of any new program, particularly with the challenges or the changes that are that have been made, and the new role for kinesiologists in a lot of these cases, there's going to be an educational opportunity that we're going to need to kind of just not have a hard time just reinforcing when we're talking to some people. So oftentimes what happens is you might run into an issue with claim number and timelines. Getting a claim number on a new referral can sometimes be a bit of a challenge. They have a criteria that you have to, within 2 days of the date of your assessment, you have to submit the intake assessment report. But you might not have a claim number, and so you can't submit the intake report, or you can't at least bill for it until the claim number comes. So a lot of the times it's going to be waiting for things to happen and calling in and making sure that you can manage the file. Again, here the second point is WSIB staff are still learning more about things, and when they are when they're not up on the latest changes to the MSK program, they're going to default to their previous knowledge, and a lot of them are OTs and physios. So in their world, back when they used to practice, perhaps they had kinesiology grads as PTAs, and so they might have to refer back to that. So I don't want you to get discouraged by all of this, but sometimes this happens, and you could be referred to another operator, or you just simply hang up and call back if it's really that big of an issue. So first scenario, let's talk about the kinesiologist who gets the client, comes straight to them. So at the orthopedic therapy clinic, I'm the lead for the WSIB program. So I'm the one who I'm actually at the top of the pyramid. When the person comes in, I can decide, based on whether or not on schedules, I could either do the assessment, or I could ask the chiropractor to do the assessment. The benefit of having the chiropractor doing the assessment is if they haven't already seen their doctor, they have to have something called a Form 8. Now, the original presentation back from the WSIB neglected to explain how you got the diagnosis. It said you needed one, but it didn't explain why. So the thing that starts before this entire process is something called a Form 8. There are 4 professionals who are allowed to fill out a Form 8. So doctor, nurse practitioner, chiropractor, and a physiotherapist, because they'll have diagnosis in their scope. Now, you can get somebody who comes in to see you for an initial assessment, and you can fill out the initial assessment report and then call into the WSIB, and then, or in fact, if you called into the WSIB and asked for a copy of the Form 8, they would say, we can't give it one to you. There's no means for them to make that available. So ideally you'd have the client provide that to you, either through a photocopy, or getting it given to them by their doctor who they might have seen. It's a lot easier if you just have somebody who's like a physio or chiro in your clinic just do the Form 8, but they're also going to do the intake assessment report. So let's just say that the Form 8's handled. We don't have to worry about this, and it's back on you again. You can fill out the initial report. You go through all of the things: subjective, objective, analysis, plan, etc. Blah blah blah. Get into block 1. Do your minimum of 5 appointments, which includes the intake assessment. Because generally speaking, I mean, KINs tend to be a nice, helpful bunch, and you're not gonna. I don't know a lot of KINs who do the initial assessment and then send the person away without anything. So often you might give them something like for symptom control or some preliminary exercises to get them going, because you only have 4 weeks or to 8 weeks max in most cases, and so we don't want to be waiting, providing any kind of opportunity for slowing down. But you go through the block 1, and then you have to submit something called a midterm report. Now, the point I didn't mention, I didn't talk about money through any of this, but all of this is billable. So you bill for your initial assessment report. Your initial, assessment report. You bill for block 1 separately. So that's 2 items there. The Form 8 is going to be billed by the primary, like the diagnosing health professional. So unfortunately, that's not in our billing. The midterm report is billable. And if the person doesn't go past that first block and you discharge them, then you can also do something called a care and summary report, which WSIB says they don't need, which is alarming to me, because they seem to be fine with you submitting a midterm report, discharging them, but without completing a care and summary report. Perhaps they're happy with the information, but everybody I spoke to at the WSIB said you could provide both reports, bill for both of them, and they will both get paid. It seems a bit redundant, but that's okay. If the person needs to continue on to block 2, every subsequent block you need to go through is about 4 weeks in duration, but pays less to the practitioner. So they're trying to motivate the professional to really accelerate care, make sure the person gets better on a timeline, and identify very early whether or not the person needs any kind of subsequent care for that. So let me give you a zoom in on the Form 8. There are different sections, A, B, C, D. I think it goes down to F or G. One section is to be completed by physicians only. Now, that would be, if they're going to be, prescribed medication or other kinds of things. Now, this section here, D3, investigations and referrals, on the Form 8, one thing that has tripped me up in the past that I want to kind of make available to all my colleagues here, this would be the ideal case. The doctor checks off rates in kinesiologists. And, I mean, if you're thinking the way I'm thinking, we were part of the creation of this, program of care. Why in the heck isn't our name along here, right beside and all these other ones? But be that as it may, don't worry about if this does not say kinesiologist. It could say, most of the time it's going to say physiotherapy, because it's kind of the most known by the medical professionals. Everybody I spoke to at WSIB has said, don't worry about it. They're not allowed to actually direct the patient to go anywhere that they don't want to. So if they end up going into your program and they work with a kinesiologist, but the referral says physio, it's not a deal breaker. Yeah, it's in fact, it might not even be looked at after that. But the important part here is to write down the diagnosis that's provided in the Form 8 in the necessary section, transfer that over into your intake initial assessment report. So this is just me saying that same thing all over again. And then find a way, I would say, work closely with your client or patient to make sure that they have filled out all of the necessary forms. So in order to get the claim number, you're going to need the claim number on this in order to get paid on it. There is a bit of a debate on the WSIB people that I've spoken to who have said you either won't be able to submit it without the claim number. I haven't had that problem so far, but getting it as early as possible is really important. That's going to be coming down from the formate being done by, let's say, the referring doctor and the client or the patient and the employer all submitting their forms. Then the case manager puts it all together, submits a claim number, and to get it from your patient as soon as you can. Now let's go into the multidisciplinary case. Person comes in, sees the physiotherapist. Let's just say, I'll just use a simple case because I think they're far more physiotherapy assistants than chiropractic assistants, but they function very similarly. So a person goes into the physiotherapy clinic, gets seen by the physiotherapist, who then completes both the Form 8 and the intake assessment report. Then decides, on the basis of that, you can sit down, assuming you're going to be mixing with different professions for this person's care, and actually decide what would be the best in this initial 5 appointments, or after the assessment, before remaining appointments. Who should this person best be seen by? And you might say things like, well, we've got a physio and we've got a kin, and we've got, maybe we need a bit more pain control at the beginning. We just do a little bit of mobilization. And so the first 2 appointments will be physio, and then we'll transfer off to kin while we get the person more active. And that would be a very typical response. And so therefore you would assume that the person would be more kin as you go along. Now let me flip it a little bit. Let's say person comes in, I do the initial assessment report, and then I say, you know what, this person still does need, they came in, the Form 8 was done by their family doctor, and I turn to the chiropractor who we have, and I say, this person could probably really benefit from some pain control. So we need that person to book in first 2 to 3 appointments with you. I think this person's going to go 8 weeks. And so we'll make sure that we plan at that. And you might even be blending it across. So you might be doing more, let's say, chiro at the beginning, and then with larger gaps between, and then starting with kin, and then getting closer to each other, like closer together. So they kind of like dovetail in a sense of ways. It's all going to be based on the patient that you have in front of you. Now, some of you watching this are inevitably going to be in a situation where you're going to be in a clinic, and the clinic director is going to give you the conversation that is going to be, we just hired this new physio and they really need to build their hours, and we need to kind of get them busy. So I want you to be able to push, even if you otherwise might not have thought of it this way. I need you to push that person some of these hours through this. So that's a possibility that could theoretically occur. And the fact is that, clinics are businesses. And so we have to appreciate that there are going to be those stresses that are going to be in there from time to time. Try to do your best, stay within the standards of the college. And I think that as long as you have open debate and discussion with your colleagues, this can go really smoothly. And at the orthopedic therapy clinic, we've got a really well, our team works really, really well together. Now, regarding the midterm reports, because this is going to be one of the questions as well, who does this? Some of the kind of friction that I've gotten from WSIB professionals, like representatives when I've called in, has been, well, it has to be done by the physio, which is not true at all. But the kins can do all of the reports. Okay. Generally speaking, though, the way I've heard it most logically explained has been that whoever is the main therapist taking care of the patient at the time. So the person comes in, gets the initial assessment, let's say by the physiotherapist, they fill out the initial assessment report and submit it. By the time the person gets to the end of block 1, they're working exclusively with the kin. The kin fills out the midterm report. And even if you call in and say, I just wanted to check a couple of things, etc., and you're told, no, the physio has to do the midterm report, I would submit it anyway, because you're talking to somebody who might not be fully up on the latest information. And so therefore, we know in their own materials that we are allowed to do these reports. Okay. The last CSO is a care and summary outcomes report. That would be the official discharge, which is actually a standard of our college as well. So if you are being seen, or if you are seeing the patient at that rate, I think that would be well within your right to complete that report. Oops, sorry, let me back this up. I'm unusually right on time. I did want to talk about one last scenario. Although this creates a really great opportunity for kinesiologists to kind of build in their autonomy in multidisciplinary groups, settings, also in their own practices, it also still allows for the opportunity for kins to be treated as PTAs through the entire process. Okay, so kins who are, if you are working as a PTA at this point, you still might be working with all of the, like, you still have to be registered with WSIB. That's clear. You might not need to be registered through TELUS because they could be billing you through the supervising health professionals number. If anybody watching this webinar has other information or can correct me on that, please provide that in the comments after this recording is up. But you could go through all of this working with the patient under the, in the way that you would as a PTA, not do any of the reports, and then still make it through. And WSIB would unfortunately still be okay with that. So that hasn't been completely, like, removed, but at least the opportunities are there for us to take advantage of. And I think more of us really should. So that's my quick look. I hope I was able to kind of enlighten you guys on this process a little bit. There is a lot of stuff that you do need to step through, and you can really only go through it yourself through the registration and taking your first patient through the process, either independently or with a colleague. I think it's going to be really worthwhile for us, and we need more kins to do this. So next steps, keep your eye out for an email with this webinar recording and the resource guide that we're going to provide for you to, step through it if you haven't done it before then. And I understand it's going to be about 30 days before we get this video up. When the video is up, please, it's called the Kinesiology Engagement and Education, or Education and Engagement Network. So please engage. We need to get more conversation going within the membership, and talk about challenges, anything you had to add. Was there anything I left out? Was there anything that you think that could have been clarified? Or if you had any additional questions that I didn't quite kind of get to, please put those in there. Now, as my shameless plug here, Savita, if you just give me 1 second. Savita did mention that my company is called Movement First, and I haven't really rolled it back up post-pandemic. I am looking at getting these really comprehensive courses going again on the assessment and interventions of different musculoskeletal conditions. And those are very comprehensive. They're going to be asymmetric. It's going to be like a video component, and then a 1 day or 2 day kind of showing up, hands-on skills learning. And I've been really excited about this thing I'm doing with Humber. And we're going to be rolling out a certificate program for people to run their own practices in primary care as a kinesiologist. So keep an eye out for that. I'm going to make sure that we utilize the Keen network as much as we can, providing some at least preliminary info. But I think that there's some good stuff coming along for kinesiologists, and I think the next little while is going to be really, really great for a lot of people coming into the profession just now. So you can get a hold of me at any of the following contact info. And once again, thank you very much for your attention, and I'll pass it back to Savita.
Thanks so much, John. That was a great presentation. So I'll give everyone an opportunity at this time to ask any questions that they have in the Q&A box at the bottom of your screen. We have some rolling in already, so I'll get started with that and I'll read you out the questions, John, and then we can have a little discussion. And as we're doing this, like I said, feel free to continue to ask your questions in the Q&A box. Okay, so for our first question, we have somebody asking here, maybe outside of the scope of this webinar, but the change from Roland Morris to Oswestry as the OM for back injury. What are your thoughts? I find that most patients don't want to disclose their sex life or discuss that in case where the documents are sent to WSIB.
Yeah, so Xana is one of the superstars that is on the vodcast, and she knows her stuff. The OM is outcome measure, and yeah, unfortunately, what the WSIB has done is they've given us zero option. So they've decided there's like one low back outcome measure. What are my thoughts? Yeah, like having been somebody who's done a lot of graduate school, you can argue a lot of different kind of elements of these questionnaires, from validity, etc. It's the card we're dealt with, unfortunately, and we just kind of have to kind of go along. If you think that there's an opportunity to use anything else, that there is a WHO like functional capacity or functional movement outcome measure, maybe you could justify going to that instead. That would be that's the only move we've got, really. Oops.
There we go. We have a couple people saying thank you for your presentation, but on to the next question. Hi, John, this is great information. In a multidisciplinary setting with physiotherapists, if I, as a kin, register with WSIB and it's time to bill BL01 at $560, can we use both myself and the physiotherapist as providers for the 5 visits in TELUS?
Yes. Now, so BL01 is that first block. Like I said before, they give you $560 in the first 4 weeks. You have to have a minimum after the assessment, minimum of 4 visits. And then it gives you less and less money the longer you take to get the person better. So when you have multiple providers, see, TELUS doesn't care who gets paid what. They just deposit the money to the clinic, and then you negotiate. So what we have is, we'll say $560, and let's say that there were like, the 5 visits. It would be, 560 divided by 5, and then multiplied by the number of visits each provider did. But that would come down to your agreement in your clinic as well. You might secondarily have the option or the situation where the clinic owner says, we're going to pay you your rate, whatever hour that you work, whether you do PTA work, WSIB work, you do specific kin work or whatever, it's going to be this much per hour. And that's just going to make our bookkeeping a lot easier. And if that's your deal with the clinic, then that's how you do it. I'm on a percentage basis. And so therefore, when we have a WSIB client and we have to see them a bit more, as the case I've got this going on right now, it means that every appointment becomes less valuable. And then so that's going to have to be your own bookkeeping kind of behind the scenes. But generally, you got the right idea. And thanks for your question.
Awesome. Next question. In my previous role, I was seeing POC clients occasionally, but they were definitely seeing the physio primarily. Just before I left, the clinic director was asking me to write the reports. I was comfortable putting my foot down and not writing a report about a client I was unfamiliar with. But is there a resource that we can point to that says the therapist who primarily sees the client should be the one to write the report?
This is the biggest challenge with this program too, because when you speak with somebody at WSIB and they contradict your knowledge, you have to have that piece of that document to say, okay, I'm going to send you a link, and here's exactly where it says what I'm trying to kind of explain to you. I have not come across that. It's just been conversation with WSIB reps, whether it be at the clinical expert line or their customer support. However, the one thing, the statement that rings in my mind right now that supports this is that it says that the program of care can be carried out by anybody who has the scope of practice that allows for all of the following types of treatments to be provided and is able to do an assessment. They're basically saying kinesiologists without saying kinesiologists. And I think that it's just a very, they're doing a very, they're trying to avoid being pigeonholed in by saying, oh, you're favoring kins and not maybe some other group, right? And so they might just be leaving that open. The problem is for us, it makes it a bit more challenging when we're trying to argue our point to WSIB. In this case, I know you're talking about your clinic director, and it would kind of be the same thing. You have to convince them of it. So they're kind of like giving us all of the support material for the argument without actually like providing the argument. But you could also refer back to the college standards. So if you had a clinic director who was like, oh, I want you to do the reports for patients that you're not primarily practicing with, you could say, the College of Kinesiologists of Ontario is really against me doing this because you're asking me to report on somebody else's therapy or somebody else's treatments. And so it could be a bit of a a decision to be made, on a case-by-case basis, but I guess you just have to stay open. And I think you did the right thing. I think that was very smart of you to do.
Okay, another question we have. Beyond the MSK POC, can an RKIN treat patients and bill for a supplementary extension or work hardening block?
Yes, so that would be the supplementary block past block 2. And yes, there's nothing stopping us from continuing on to that. When you get to that point, you're talking to a case manager. And I think that now we start getting into that part of WSIB treatment that a lot of other health professions hate, because historically it hasn't really paid that well when you're outside of a program of care. The program of care, that because it provides a structure, it also guarantees a certain amount of funding. But when you're going like session to session, or possibly if you're going to speak with a case manager, you're gonna have to do this on a case-by-case basis. You could really kind of get that person's feedback. That's the best way that I would do this as well. I don't see any other questions, but if I have just 3 seconds to add, well, there's like 5 minutes left till 8 o'clock. So there was one thing I didn't put a slide in because I wanted to make sure that I had enough time for everything else. But here's the thing. Hey, Bridget. Okay, sorry, I just saw a question pop up. When you're going through all of this, we're talking about WSIB, the program of care, as being a model for you to become more autonomous, to build your career as a clinical kin. What else can you do there? Well, let's talk about all those other things that we excel in that other professions in these clinics tend not to. If you saw a previous presentation that I had, the physios are going on about being experts in exercise. However, like I had this meme that said, we're experts in exercise. And physiotherapist says, we're experts in exercise, and also physiotherapist, let's do acupuncture. Because every single one of them is certified in acupuncture, and that's what they want to do. And that's where their interest is, regardless of their scope. So scope, competence, again, that argument again. But let's talk about what the kins can really bring. You've got somebody who came to you from an employer. You can contact the employer and say, hey, do you know that our clinic offers these work hardening services? Do you need PDAs done? Do you need ergonomics services in order for that as well? You can use this as an opportunity to reach out. And like I said before, the people who get treated best at businesses are the ones who bring in as much or bring in revenue. And if you can bring in additional clientele in terms of like an entire employer, which could mean dozens of patients, to everybody, not just the kin doing the PDAs or ergo or WSIB, and then going to the person's family doctor, because hopefully you take that information and say, hey, do you know that we do this WSIB program? We provide great care and it's not going to cost your patient anything. And then you use that as a way to get them thinking about kins more. Because unfortunately, 10 years into regulation, I mean, it's wonderful to see this right here, but I thought by now we would see kinesiology clinics all over the place. And we haven't really seen that. And I think it's time that we really need to get motivated and get that out there. Anyways, let's get to Bridget's question. She's a good friend too.
All right. So next question we have is, I had a program of care patient whose claim was denied before they completed the first block. I called WSIB and the specialist said I could talk to him because the claim was denied and the customer support said there was no one for me to communicate with. It was left for the patient to appeal. She chose to go privately pay, but I was frustrated with the refusal of communication. I'm wondering if this depends on the reason the claim was denied, that they could not disclose it to me.
But yeah, that is a tough one. But there is a contact email that we have available to us that we could go. It kind of like moves us above the clinical experts and everybody else, and that's going to be in the resource guide as well. If you get to these like operational questions and these things, you're hitting a roadblock, people are just, for some reason you're not getting you're not able to kind of like pursue or move forward a claim or help a patient in a certain way, you can send your concern to this email and they will handle it. And I do believe it's at the level of like the Jesse Farron and Flavia, the two presenters of the previous WSIB webinar as well. So there might be a little bit of there's something to be done, but yeah, unfortunately a lot of it's like trying to argue with a cop. Like you're just not gonna, it doesn't matter how logical your argument is, often the answer is the answer. And I feel badly for the patient because the person clearly is trying to get better.
Great. If there's no further questions, John, any final comments or remarks from you? Anything else you wanted to add in our last minute here?
Just really appreciate everybody coming to the presentation tonight. And if you guys have anybody has any questions, feel free to email me, add me on LinkedIn, all of that stuff. There's going to be some really great stuff coming out before the end of the year and even more great stuff next year. So please stay tuned, and I'll do my best to try to get as obvious as possible to everybody. So thanks for your time tonight.
Awesome. Thanks so much. Big shout out to John Gray for our presentation today. Lots of great information. And as he mentioned before, it will be posted on the Keen section of our website. Just give us a couple of days and we'll be able to post that, I want to say around 10 days or so. Keep an eye out for the resource guide as well. And if you have any questions, feel free to message OKA or John Gray directly. Thanks so much. I hope everyone has a great evening.